We're going to move on with Dr. Justin Morgenstern. I think we're doing, this is going to be, he can't be here, so he's going to be up there. He's going to talk about tracheostomy disasters, so I'm not going to listen because that would make me nervous. Oh, there he is.
All right. Good morning. I hope that you can see and hear me. Gotta say, I'm pretty upset that I don't get to be there with you in person, having drinks, seeing all your faces right now. But I gotta say, as much as I've come to hate these Zoom calls over the last 3 years, I am very grateful this morning that despite waking up yesterday to a house just chock full of COVID, I still get the opportunity to talk to you this morning. So thank you so much to the EMU organizers for putting all this together at the very last minute. And let's jump in. So I was called to resus stat. There was a patient there in respiratory distress, SATs in the 70% range despite a non-rebreather. There was stridor, there was accessory muscle use. The patient looked really sick. But let's be honest, that in and of itself is not going to get my heart rate up, right? That's bread and butter emergency medicine. We deal with that every single shift until I walked into the room. And I looked down and there's a piece of plastic sticking out of the front of this patient's neck that nobody told me about. The first time this happened to me, I was just a month out of residency. I had never seen a tracheostomy outside of the ICU. I never touched one. I never got the chance to replace one as a resident. And I'll be honest, I freaked out. I knew exactly how to deal with respiratory distress. I had practiced that over and over again. I had no idea how to deal with a trach. And this patient looked like he was going to die. So I'm not proud of it, but I sort of froze in that moment. And to be honest, in emergency medicine, we pride ourselves on our ability to handle the unexpected, to troubleshoot. We love that. But personally, when a patient is very sick, when somebody's life is on the line, I really don't want to have to come up with a new plan on the spot. I don't want to have to be creative. I just want to know exactly what to do and get it done. So as I sat there panicking that day, I realized I really need to have an approach to tracheostomy disasters. And that's what we're going to go over today. Now, admittedly, it's pretty rare that we see a patient with a tracheostomy in our emergency departments. It's going to depend a lot on your local hospital and who's living in your community. But there are a lot of patients with trachs who live in the community. So this is a patient that could come into any emergency department, any day, any time. Personally, I've had to deal with this in multiple small community hospitals with no backup on opposite sides of the world. So we all need to be prepared for the bad things that happen with tracheostomies, the tracheostomy disasters. Today, I'm going to try to make this very, very simple. When it comes to trachs, there are really just two ways that patient is going to present. They're either going to present in respiratory distress or with bleeding. And for each of those presentations, there's just two questions that I want you to focus on. For the patient in respiratory distress, I want you to ask, is the tube blocked or is the tube in the right place? Displacement and obstruction, that's your entire assessment. For the patient who's bleeding, two questions. Can I stop this bleeding with direct pressure, or do I need to find a way to pinch off the innominate artery? Two presentations, two questions. That is the entire lecture in a single slide. I guess you could go get some coffee now, but let's go through them in a little bit more detail. The much more frequent presentation is going to be respiratory distress, that patient that I started with. Now, obviously, a patient with a trach can have any of our normal causes of respiratory distress. They can have pneumonia or PE or pneumothorax or asthma, but you all know exactly how to work those up. You do that every single day. So our job with a patient with a tracheostomy is to rapidly rule out the trach as the source of our problems so that we can just move on and deal with all that easy stuff that we deal with every single day. Just eliminate the trach as the source of the problem as quick as possible and move on. Now, for any sick patient, call for help early. Get your team around you nursing. You definitely want RT here if you work in a country that has it. Some places will have access to ENT or anesthesia. Sure, give them a call. But let's be honest. Even in the biggest hospitals, downtown Toronto, middle of the day, banker's hours, if you have a really sick patient with an airway issue, that help isn't going to get to you quick enough. So we need to be prepared to manage these issues by ourselves. Of course, we always start with the ABCs. I want to make one slight adjustment in this patient. Unless you know for sure where the patient is breathing from, you need to get oxygen both over the mouth and nose, but also over the trach. Double up to make sure that your patient is getting oxygen. And then we come to the two key questions that we're going to ask every time we see a tracheostomy patient in respiratory distress. Is the tube displaced? Is the tube obstructed? And that's the entire tracheostomy assessment. And everybody here is basically familiar with doing this, right? This is sort of what you run through when you have an intubated patient. I think a lot of people use that DOPES mnemonic, right? So displacement, obstruction, and then pneumothorax, equipment, stacked breaths. But I really, really just want you to focus on the first two, displacement, obstruction, because I'll tell you, the rest will just take care of its stuff as we go through this algorithm. So what do we actually do? What are the actual practical steps to do here? Well, first, if there's anything attached to the front of that trach, just take it off. Sometimes there's going to be a humidifier on there or a speaking valve, or if the patient came in on a ventilator, doesn't matter. If there's anything attached to the front of the trach, take it off because we don't want any equipment issues. And then the key first move is remove the inner cannula. Most trachs that you see will have a hard plastic bit that will stay in the trach all the time, and then a softer piece of plastic that you can take in and out. Your first move is take out that inner cannula. And actually, a good percentage of the time, this will just solve your problems because that inner cannula frequently gets blocked off with mucus or other secretions. And if you remove it, the obstruction is gone. That's the whole point of having that inner cannula, so you can swap it out when it gets dirty. So first step, remove the inner cannula. If that didn't solve your issues, the key next move is to take one of those soft suction catheters that we use once the patient is intubated and pass it down the airway. If the suction catheter passes, you're done. Because if the suction catheter makes it all the way to the lungs, you know for sure the trach is not obstructed, and you know for sure the trach is in the right spot. So you can take a deep breath and just move on with your normal assessment. Now, I would always double check this with waveform capnography, but if the suction cat passes, the trach is not the problem. So we can relax. Hook up a BVM if your patient needs some help with ventilations. Grab your ultrasound, do an ECG. If you're still old school, you can grab a chest x-ray. Do the things that you would normally do to work up pneumothorax, pneumonia, asthma, whatever it is. Super easy. In the patient with a tracheostomy, your job is to rule out obstruction and displacement. Passing the suction catheter is your go-to move. Now, these days, a lot of people might have something that's even better than a suction catheter. If you work in a place that has an intubating bronchoscope, or actually even one of those NP scopes, and you can get it to the bedside immediately, I would use that instead of a suction catheter. Same principle. If it passes into the lungs and you can see the carina, again, you have ruled out obstruction and displacement. But the scope gives you a ton more information. If there's a problem, you might be able to diagnose it and fix it right away. With the scope, you know exactly what's going on with that trach. So I think this is a really nice bonus if you have one of these. Hopefully someday everybody has access to these. They can just become standard of care because they are brilliant. But for most of us, the suction catheter is just going to be good enough. What do we do if the suction catheter won't pass? So at that point, you know that the trach is the problem. If the suction catheter won't pass, or the bronchoscope if you have it, the trach must be either obstructed or displaced. So if the trach is the problem, eliminate the problem, deflate the cuff, and just pull out the trach. And once the trach is gone, you can't possibly have a problem with the trach, so you've solved your problem. Congratulations. Now, of course, I guess that patient probably had the trach for a reason, and you just pulled out their airway. So we're probably going to have to do some airway management, but at least we solved the initial problem. And honestly, if the patient is getting better at this point, if they're starting to breathe more comfortably, if their SATs are improving, you don't have to rush to do anything at this point. You can just provide some oxygen and call for help. Wait for somebody to arrive with the experience. Wait for somebody with one of these intubating scopes to arrive. Take your time. But of course, this is more of a resuscitation talk. So we're going to assume that this patient is still sick, that we still need to act after pulling out their trach. And what we do next is guided by one key question. does this patient have a patent upper airway? There are patients who literally do not have a connection between their mouth and their lungs. Sometimes it's surgical, so a laryngectomy, or sometimes there's just a massive tumor, whatever it is, that obviously completely changes things. Luckily for us, the vast majority of patients that we're going to see in an emergency department do have a patent upper airway. And so what does that mean? For most of your patients, the first step after taking out that tracheostomy tube is super easy. Just manage the airway exactly like you always would. You can use a BVM and ventilate them through their mouth and nose. You can put in an LMA. You can intubate them through their mouth. Just manage the airway exactly like you always would, with two caveats. Caveat number one, you don't know why that trach was put in the first place. So just assume that this is going to be a difficult airway, which means try to intubate from above, but be prepared to move through your steps, move to your backup much quicker than you normally would. And number two, if you have an extra set of hands available, it makes sense while you're working on ventilating from above, have somebody else work on the neck at the same time. The other caveat here is that if you're ventilating through the mouth and nose, you still have a big open hole in the front of the neck. And so you're going to get a pretty good air leak if you're just using a BVM or an LMA in the mouth. So you're going to need to have somebody take their hand and seal the front of the neck to make sure that your ventilations are getting into the lungs. But for most of our patients, it's scary, but once you take out the trach, just manage them exactly like you normally would through the upper airway. Now, if the patient doesn't have a patent upper airway, or you try through the mouth and nose and you fail, now we're going to have to oxygenate and ventilate through the stoma itself. And in my mind, the next step is pretty clearly just ventilate through the stoma. I will admit there's a bit of a debate here. In the past, a few different times, I've just grabbed a replacement tracheostomy tube and shoved it straight back into the stoma, and it worked. It was quick and easy, but it is much riskier to go straight to intubating the stoma. Because if the problem originally was a displaced tube, there might be a false trach through the soft tissues. And if you just go shoving something in there blindly, you could make that false trach worse. You can get lost in the soft tissues. And obviously, most of our patients don't look like this model here. And then even if you go and try to ventilate through that trach that you just shoved in, but it's misplaced, you can end up causing significant subcutaneous emphysema. You can distort the entire neck. And you could take an airway that was going to be difficult already and transform it into an impossible airway. So in my mind, I think it's really clear the first step here is to just focus on ventilation through that stoma. I think that is the safest plan. Now, obviously, our standard BVM mask is not designed to make a perfect seal on your neck. That's not what it does. So you have two options. Either grab yourself a pediatric BVM or get a small LMA, like a size 2, and both of those should be small enough that they should make a nice seal around the stoma. And then just like when you're ventilating through the mouth, you're going to get an air leak through the neck. If you're ventilating through the neck, you might get an air leak through the mouth and nose. So you might need to get an assistant to cover the mouth and nose to make sure that your ventilations are actually reaching the lungs. Now, if ventilation fails, we get to the scariest part, and we're going to have to intubate the stoma. And in my mind, the best approach here is very clear if you have a fiber optic scope available. So I have one at one of my hospitals. So I would just grab our intubating bronchoscope, advance until I see the carina, and railroad a tube in. If you have a replacement trach, you might as well use it because it's going to be a lot easier to secure to the neck when this is all over. Keep in mind that there's a huge amount of variation in the external size of these different trachs between the different manufacturers. And at this point, the patient is probably sick enough that you just want to get that tube in as quick as possible. So the safest thing to do is pick a trach a size smaller than the one that you just pulled out. It'll always be written right on the cuff of the trach. So just pick a smaller size. A lot of the time, you won't have a replacement trach available, so just use a small endotracheal tube, exactly like you would if you were performing a crike, a small 6.0 or even 5.0 tube, and just use that as a replacement. Now, I understand most people, unfortunately, these days still won't have that intubating bronchoscope, so you're going to have to do this blindly. And you might be tempted to use a bougie, and there are a lot of people who recommend using a bougie here. But the people who do this a lot, the people who manage trachs all the time, seem to be universally anti-bougie. They do not like the bougie because the bougie is very stiff. And if the problem here was a false passage, shoving that bougie into the false passage, it can easily push its way through the soft tissues and just make the problem worse. So the preferable device here would be one of those tube exchangers because they're softer and more flexible and less likely to make the problem worse. But really, we just need to get something small through that stoma and slide the endotracheal tube with a replacement trach over top of it. If we back all the way up to the beginning, respiratory distress here in a patient with a tracheostomy, it is actually very, very simple. 2 questions. Is the tube obstructed? Is the tube displaced? The go-to move is grabbing that soft suction catheter or bronchoscope and passing it through the trach. If it passes, the trach is not the problem, and do your normal assessment. If it doesn't pass, the trach is the problem, so just take the trach out, and then you can focus on oxygenation, ventilation, first through the mouth or nose, and then through the stoma. Super easy. If you can remember those very simple steps, you won't have to panic like I did. So let's move on to problem number 2. And honestly, this one can get very, very scary, even if you're totally prepared for it, because bleeding and the airway just don't mix. When a patient's bleeding elsewhere in their body, if you have a GI bleed or a trauma patient, honestly, we generally have a little bit of time because it takes some time to lose enough blood to become hemorrhagic, you go into hemorrhagic shock, to get really sick, right? But bleeding and the airway is a completely different beast because these patients don't die of hypovolemia. It only takes like 150 mils of blood to completely fill the airway. So these patients are drowning in their own blood, and it can happen very, very quickly. Luckily, the steps here are very, very simple. And unlike hemoptysis, which is a very similar scary presentation, when a patient is bleeding from their trach, the source of the bleeding is usually at least somewhat accessible, which means that we can use that best tool that we always have to manage bleeding, which is direct pressure. Now, for a resuscitation kind of talk, I'm focusing on the really large bleeds today, but let me say, sometimes you'll see a patient with just a tiny amount of blood. You can stop it just with the barest amount of pressure, or you use a little bit of cautery, but I want you to be very, very cautious about those patients because sometimes that small bleed was a sentinel bleed, and the next bleed will be the one that kills your patient. These are very, very high-risk patients. The problem is something called a tracheoinnominate fistula. So you get a direct connection between the innominate artery and your trachea. That means you get arterial bleeding directly into your airway. And yeah, that's as bad as it sounds. So high-risk patients, in my mind, every single patient with a tracheostomy bleed, I don't care how small it is, every one of these patients needs an ENT consult before they go home. But my focus is on the bigger bleeds. So let's talk about the patient who's bleeding a lot. Once again, obviously, we're going to call for help. This is going to be more important than the patient in respiratory distress because this is often a surgical problem that we can't solve ourselves. I have no way of repairing a tracheoinnominate fistula. So call ENT, but who you really need probably is a vascular surgeon. So first step, call for help. And then the key move here is to try to get some direct pressure on the bleeding. And the best way to do that, if the patient has a cuffed endotracheal tube, is to hyperinflate that cuff. Add an extra 20 or 30 cc's of air to that balloon. You might want to play with this when you don't have a sick patient because you don't want to do it too quickly. And a few times when I've been trying to get pictures of it, I've popped the balloon. So add 20 or 33 cc's of air, but do it nice and slow and overexpand that balloon to create pressure inside the trachea. And the good news for us is that this works between 85 and 90% of the time. This is likely to work for you. This is such an important life-saving technique that if the patient came in with an uncuffed tube, I think you got to swap it out for a cuffed tube. Now, if there's a lot of bleeding, I don't want you to get lost. I don't want to cause an airway problem here. So make sure you use a tube exchanger to swap the tube out, but get a cuffed tube in there. If you don't have a cuffed tracheostomy tube, just put a cuffed endotracheal tube in there, get some kind of cuff inside the trachea, overexpand it, and try to get some direct pressure on the source of bleeding. While we're waiting for that direct pressure, that hyperinflation to work. If the patient has any hint of a coagulation problem, just reverse it. I usually like to talk evidence-based medicine. This is not a realm of evidence-based medicine. There are no studies here. And remember, 50, 100 mils of blood might kill this patient. There is no evidence. Just if there's a chance that you can reverse the coagulopathy, just do it. So if they're on warfarin, we're going to get the PCCs going. If they might have low platelets, we're going to give some platelets. If they're in renal failure, some DDAVP. I'm almost certain that TXA is not going to work for arterial bleeding. But again, 100 mils of patients, 100 mils of blood might kill this patient. If I had time, if I have resources, if I have an open IV, I'll probably even give TXA here. So anything we can do to stop the bleeding, get it into the patient as soon as possible. Hopefully, again, this is going to work 85, 90% of the time. So hopefully that's all you have to do. But what do you do if the patient continues to bleed despite that overinflated cuff, despite the reversal? The next move is we have to protect the lungs. So the bleeding usually occurs right at the tip of the trachea, where there's been some pressure or some friction over the time. But that's a problem because that means the bleeding is below the cuff. And so right now, all of the blood is pouring directly into the patient's lungs. That is not a good place for blood. So we need to get a cuff lower than the level of the bleeding so that even if the patient continues to bleed, it doesn't go into the lungs. So you got to pull the trach out and put an endotracheal tube in. The best way to do that, if you can, is just to intubate through the mouth and just get that cuff deeper than you normally would, hyperinflate it again so that it's below the level of bleeding. If the patient is still bleeding, you want to see that blood coming out of the stoma, coming out of their mouth and out of their nose so that you know it's not going into the lungs. And then our last step is we have to pinch off the innominate artery. So you're going to take a finger. You're going to put it into the stoma. You're going to direct it down towards the chest as far as you can go, and you're going to push up against the back of the sternum. And then I will also take my thumb and put it into the sternal notch and pinch as hard as I can in case that innominate artery is a little bit hard. And you are going to pinch like this patient's life depends on it. And you're going to leave your finger in there. You're going to keep pinching all the way to the operating room. You're not going to let go until the vascular surgeon tells you you're allowed to. This is so important. This is the only thing that's going to save this patient's life, that if you can't get your finger into the stoma, if the stoma is too small, or if your finger's too short and you can't get all the way down to the innominate artery, you're going to take a scalpel and you're going to make a vertical incision and make that stoma bigger just so you can get your finger in deep enough to pinch off the innominate artery. So again, bleeding from a tracheostomy, it's very, very scary, but luckily for us, the steps are very simple. Overinflate the cuff, get that direct pressure, reverse any coagulopathy. If that doesn't work, get a cuff in deep, protect the lungs, finger into the stoma, pinch off the innominate artery, get to the operating room. Tracheostomy problems are pretty classic emergency medicine. They're very low incidence. You're not going to see these every single day, but they are very high risk. You are never going to get enough clinical experience to master these problems. But when the patient rolls through your door, you better have mastered them. So how are we going to manage that? This is one of those things where we just have to have simulated it. And it'd be great if you can do this in a sim lab, but for most of us, this means we got to do some mental simulation. We got to run through these steps on a regular basis so that we're ready for that once in a decade presentation. Luckily for us, those steps that we have to remember are very easy. Respiratory distress, think displacement, think obstruction. Your go-to move is passing the suction catheter. If it passes, the trach isn't the problem, move on. If it doesn't pass, the trach is the problem, take out the trach, oxygenate, ventilate through the mouth, through the stoma. In a bleeding patient, first step, hyperinflate that cuff. Reverse any coagulopathy. If that doesn't work, we need to cuff deep to the level of bleeding, protect the lungs, finger into the stoma, pinch off the innominate artery, and get to the OR ASAP. These are very rare presentations, but if you can remember those very simple steps, you will save somebody's life during your career. Thank you very much.
Thank you, Justin. You can see us a bit, right?
I can hear you. I can see you, yeah.
Okay, I think we have a couple of questions. Your talk did make me feel a little bit better. I'm a little less nervous, thank you. Okay, Jashi.
Hi, Justin. So we do have a couple of questions from the audience. Can you hear me?
Absolutely.
Perfect. So there's a mention of post-laryngectomy patients who obviously don't have a connection between their oral airway and their lungs. And sometimes you know this on history, sometimes there's a medical alert bracelet, and sometimes you don't know. So the question was, why not just approach the trach and forget going from above, intubating from above?
Yeah, so this is one of those areas, like there's clearly never been an RCT, there are no studies. So this is all a lot of opinion, and I've had to rely on people who do this a lot. And I think the basic reason is if you have had to remove the trach, there's probably a problem with the trach. And so the likelihood is that there's going to be a false passage, there's going to be something else there. And which do you have more practice in? Do you have practice intubating in a stoma, or do you have practice doing upper airway stuff? We're all very, very good at managing the upper airway. And so although I would give up on upper airway stuff really quickly, I think you'll know within minutes if your attempt at an intubation through the mouth is going to work or not. And I would go for it because that's what you're the master of.
Sounds good. And then just in terms of specifics for those of us who may not do trachs or replace trachs very often, what size of ETT tube are you using? And how far are you putting it down when you have to inflate it to stop some severe bleeding?
Yeah, so I don't think any of us are doing this all that frequently. I guess maybe there's some ICU docs in the audience. So if you're just replacing the trach, say you have a respiratory distress patient, you only need that cuff to get immediately into the trachea. So like as soon as you see the cuff pass inside, it's in the trachea because there's no space. The way I would approach this for a bleeding patient is I would much rather have them survive on a single lung rather than have two lungs full of blood. And so I'm just putting that tube in as far as I can on that first pass, inflating the cuff, and then I'd probably grab the ultrasound to see lung sliding, and I might pull it back until I can see bilateral lung sliding. But I want it as deep as possible early so I know I have at least one protected lung, one lung that will oxygenate for me.
Okay, thank you, Justin. That was great. And we're going to move on.
Take care, guys.
All right, see ya. See ya.